Welcome everyone. In this session we are discussing the recall forensic medicine questions that had come up in the NEETPG examination in 2022. Okay, so as you know, the exam has just finished few days back, in fact 3 days earlier, and based on the recall of the students, there are 13 questions that had come up from the subject of forensic medicine. So it's a good number of questions that have come up for the examination from forensic medicine, and as far as I have reconstructed the questions as per the directions of the students, the questions appear to be of moderate degree difficulty. So the paper had good, moderately difficult forensic questions only. Some were very mildly difficult direct forensic medicine questions which are commonly asked in examination. So it was not a very difficult paper as far as forensic medicine subject was concerned, barring one odd question here or there where the difficulty level was more. 11 to 12 questions were of mild to moderate difficulty only. Okay, without wasting any more time, let's try and begin discussing our first question. The first question is from the subject of legal system, or you can say topic of legal system. The question says, during a court trial, the lawyer of the defendant asks a leading question. Okay, the opposition lawyer raises objection. The judge sustains the objection and asks the defendant lawyer not to ask leading questions as they are not permitted except. So basically there is a lot of history given in the question, that there is a defendant lawyer, there is a who is asking a leading question. So it is specifically given that defendant lawyer is actually asking a leading question. The opposition lawyer, which means probably the lawyer of plaintiff or prosecution, is raising an objection. The judge is sustaining the objection by saying that leading question can only be asked during what circumstances, because the question says that leading questions are not permitted except, which means which is the area where leading question is permitted. So the question is very simple. It's only that it is twisted in a way so that it becomes little difficult to understand. The answer is very simple. The answer is option number B, because leading questions, when we say, can be asked in the court of law during two scenarios. One, cross-examination, where the leading question is asked by lawyer of opposite side. So whosoever is cross-examining the witness, he can ask the leading question. And number two, during hostile witness scenario, where the leading question can be asked by self lawyer, or you can say lawyer of the same side, to prove the hostility of his own witness. This is something which we talk in detail when we talk Indian legal system during our classes. Another important scenario where leading questions are permitted is scenario called as dying deposition. But as it is not practiced in India, it's a Western concept, so we generally don't talk in detail about it. Okay, now what are the scenarios where leading questions are not permitted? So leading questions not permitted. First is examination in chief, also called as direct examination. Okay, and second is re-examination in chief, also called as re-direct examination. Both these examinations are conducted by the lawyer of the same side. So the lawyer who will conduct examination in chief and re-examination in chief will be the lawyer who has called the witness himself. Okay, so direct examination, redirect examination are conducted by lawyer of the same side, and whenever lawyer of the same side is having any kind of talk with his own witness, leading questions are not permitted. When the lawyer of the opposite side is having a talk with the witness, leading questions are permitted. That concept is called as cross-examination, with one exception, that is, if the witness turns hostile, the lawyer of the same side may ask leading question to his own witness to prove the hostility of the witness itself. Okay, so this takes care of the discussion of this concept of question. Let's move to the second question. Second question came from the topic of medical ethics. Okay, let's read the question. Question says, a female comes to a gynecologist for hysterectomy. Okay, so hysterectomy is removal of uterus. It's a major surgical procedure. The doctor discusses the advantages and disadvantages of the available procedures with her and obtains her consent. So what has the doctor done? The doctor has discussed, okay, the doctor has discussed the advantages and disadvantages, which is called as the pro and the cons of the available procedures to conduct hysterectomy, and then later on the doctor obtains the consent of the female. This type of consent is called as, so question basically is really straightforward. The consent has been obtained after, if I have to sum up this question in one line, it would be the consent has been obtained from the patient after discussing the pros and cons of the available procedures. And this kind of consent very plainly is called as informed consent. So you inform the patient about the condition, the available procedure, the morbidity, modality, side effects associated with the procedure, what are the alternative procedures available, what would be the morbidity, mortality, side effect, possible outcomes of the alternative procedure. So you give all the information to the patient, and once you have supplied all the information to the patient chooses with full self autonomy. So when informed consent is being talked about, always remember a very important word, that is self autonomy of the patient. Self autonomy of the patient is, after receiving all the required information from the doctor, the patient is able to analyze all the information by himself without any coercion, without any pressure, and gives a very free voluntary consent regarding what does the patient want to have on his body or her body. This kind of consent is called as informed consenting. Okay, we again talk about informed consent in our classes of medical ethics. Okay, so all those students who have paid attention to informed consent there would have been very easily able to answer this kind of consent. A very important kind of consent has been probably came as an option in this question, that is in option number D, blanket consent. This is again one consent which we do talk in our class. Blanket consent is a scenario where you take consent for multiple processes or procedures in one go. That is, you put a blanket over everything and you take a single consent for everything. Okay, for example, if you want to operate a patient, you need to take anesthetic consent separately and operative consent separately. You need to explain the risk of anesthesia and operative procedure separately to the patient. But if you do not take these separate consent, you just take a simple consent by explaining the operative procedure, and anesthetic consent is not taken separately. Okay, that would be called as a blanket consent, assuming that patient, if needs to be operated, the patient should know that he will be anesthetized. No, the kind of anesthesia which has to be introduced into the patient is the choice of the patient himself. It is not the choice of the doctor. Okay, so blanket consent has to be condemned. So it's a condemned form of consenting. Okay, let's move to question number 3. Again, one more question from the area of medical ethics. The question says, a doctor who is drunk performs surgery and injures a major vessel. The patient dies. This is, the options are civil negligence, criminal negligence, dichotomy, therapeutic misadventure. You see, if we see the options in the question, there are one or two options which have to be eliminated before we actually get to the correct answer itself. The first option is option number D, therapeutic misadventure. Now, therapeutic misadventure is a situation in allopathy system of treatment where the control of a certain aspect of drug is not in the hands of the doctor. For example, if I would say that there are 10 patients who come to a doctor on a single day and all of them complain fever, and the doctor prescribes them paracetamol, which is drug of choice for fever, pyrexia. It is possible that out of the 10 people, 5 people the fever may break, in another 5 the fever may not break. That's the therapeutic index of the drug. Okay, sometimes the fever doesn't break on single dose. Okay, now out of those 10, 9 people do not have anything as a side effect. One person has a severe side effect. Let's consider that. Now that may be an example of therapeutic misadventure. You know, something has gone wrong with the usage of that drug, but that does not mean that that drug was not warranted for the condition. So everything is always not in the hands of the doctor. Okay, now if you Read the question well. A doctor who is drunk performs a surgery, injures a major vessel. It's not something which would be in line with therapeutic misadventure, because surgical procedure is in the hands of the doctor. It is not a drug misbehaving. Okay. Dichotomy is fee splitting between doctors. So it has nothing to do with injuring of a vessel of the patient. So it is obviously not a choice. Civil negligence. In civil negligence, the concept is compensation money. Okay. So what happens is, a doctor treats a patient. The patient thinks that the doctor has treated him negligently, because of which the suffering of the patient has increased, and the patient wants compensation for increasing his suffering, and the patient drags the doctor to the court. The doctor has to pay the compensation if the court decides that it is the negligence of the doctor which has led to the increased suffering of the patient. This is called as civil negligence. There is no punishment allocated anywhere. Okay. But what if the doctor commits a negligence because of which there is a severe loss to the patient, or the patient die? In this scenario, the state prosecutes the doctor inside of a criminal charge of negligence, because this becomes now a concept of criminal negligence. So more or less, how do we define a criminal negligence? State prosecuting a doctor for committing a gross mistake, or I should say negligence, due to which the patient suffers a severe loss or the patient die. And if the patient die, this prosecution happens under IPC 304A, okay, which is punishment for death due to negligence. So in this scenario, the doctor will be booked under IPC 304A, that is punishment for death due to negligence, because of the negligence of the doctor, the patient has died. And what is the negligence of the doctor? He has consumed alcohol, and under the intoxicating effect of the alcohol, he is operating. This is unethical practice by the doctor, and that unethical practice has led to a negligence where a patient has died, which is concept of criminal negligence. Okay, so correct answer here is option number B, criminal negligence. Okay, this is a scenario and situation of criminal negligence. Okay, question number 4. This comes from the topic of injury. So one picture based question. So a lot of inputs were there from the students that a particular kind of picture had come, or probably a kind of picture had not come, but maybe a question had come exemplifying what are the findings in a picture. What I could understand is that a picture of a hand was given, and in that picture we could see presence of multiple cuts on the hand. Okay, I do not have the exact picture with me which was shown to you, but in the exact picture that has come up in the examination, probably the cut edges of the fingers, the cut wounds on the finger, the edges were clearly seen, because the bleeding was not present, because the fingers were cleaned, so that cut edges were clearly seen on the fingers. So there were cuts which were present on the interphalangeal areas, and the question that was asked was, the wounds which are shown in the picture are highly suggestive of what? Now, cuts in the palms or in the interphalangeal areas will represent an attempt to hold or push away a cutting weapon advancing towards the body. Okay, so consider if there is a cutting weapon which is advancing towards the body, and the person can see that a particular cutting weapon is coming to assault his body, what will be the normal reaction of that person? He will try to hold that weapon from his hand, or he will try to push it away from his own body, so that he should not have cuts on the vital areas of the body. And in the process of holding that weapon or pushing it away, he might end up developing cuts on his fingers or palm itself. And what is this phenomena called as? This phenomena is simply called as defending oneself from an attack. So these wounds are nothing but defense wounds. Simple, very, very simple. Okay, these are not hesitational cuts, because hesitational cuts are produced onto the body if a person tries to commit suicide. And while a person tries to commit suicide by cutting one of the major vessels of the body, he may not have the courage to give the first cut as the decisive cut. So holding on to the weapon close to the vessel of eventually which vessel needs to be cut, holding the weapon close to that area, the person hesitates for a while. In the process of that hesitation, he ends up giving multiple superficial cuts. So in this picture, there is no vital vessel to be cut in the palm, where people would believe that cutting those vessels would eventually kill them. So that's not the area to commit suicide. So hesitational cuts are not the options. Okay. Self-inflicted wound, another important area that needs addressing here. Self-inflicted wounds are those wounds which a person inflicts on his body himself, and the motive is that he wants to blame somebody else for its production. Okay, so consider when a person chooses to self-inflict his body, where would he want to produce those injuries? If I am that person who wants to self-inflict myself because I want to blame somebody else, I would like to cut an area of my body where my hand can easily reach. I would like to cut that area very superficially, so that there is no lot of bleeding, I don't have much complication, and it should not be a vital area of the body also. Okay, so that if I cut it today, tomorrow I may have a lot of complications. Fine. And I would not give any of these cut as a deep cut, because deeper cuts would bleed more. Fine. So if you look at the presence of cut in the palm, that's not the area where usually people will end up giving self-inflicted injury, because this is a vital area of the body. You need to handle things from here. So commonly people don't cut their palms. Commonly they may end up cutting their forearms, they may end up cutting their upper arm, they may end up cutting their chest. All those cuts are generally superficial, they are not deep, and they are unilateral. Unilateral means depending upon dexterity of the person, they may be on the right or on the left hand side of the body. So obviously cuts on fingers don't represent this phenomena also. So self-inflicted injuries are also out of context. So best answer is defense wounds. Okay, let's move to next question. Question number 5. Question number 5 also comes from the section of injury, this time from the section of firearm injuries. Okay, it says identify the weapon and range of shot. Identify weapon and the range of shot. A picture was given along with the question. Lot of students had mixed reactions regarding what kind of picture was given. What I could understand from the reactions and recall of the student was there was a kind of picture given where there may be an entry wound somewhere on the face or on the temple or on the cheek. There were presence of lot of dots on the eye and the cheek area, probably representing tattooing from the firearm, gunpowder particles coming out from the firearm. But largely the students have given an input that the entry wound which was present somewhere on the face, the entry wound was circular and normally small in size. So we have a circular, okay, hold on, let me write it with a darker color. We have a circular entry wound, and along with the circular entry wound you can see there is presence of lot of tattooing around entry wound that can be seen. Nothing else can be seen around the entry wound. So there is circular entry wound with tattooing. No burning or singeing or blackening can be identified. Okay, now if we look at the kind of picture, a circular entry wound associated with tattooing around the entry wound, if you look at this picture, by looking at this picture we can say one thing for sure, that this kind of a picture can be generated by a bullet coming from a rifled firearm. Okay, a bullet which is coming out from a rifled firearm. So if you look at the options, from the options we have 4 options: shotgun intermediate range, or it is a shotgun near range, or it is a pistol coming from near range, or a pistol close range, something like that. 4 options were given. When we look at these options, shotgun automatically is ruled out, because a single round entry wound surrounded by tattooing around it can be produced by a rifled bullet, or a bullet coming from a rifled weapon. So out of the 4 options, pistol is the rifled weapon, shotgun is not the rifled weapon. So 2 options are automatically negated. Out of the remaining 2 options, now what we need to see is whether it is a shot from pistol near range or whether it is shot from pistol close range. Now if we go back to what we kind of understand about the ranges of firearm. So there are few ranges. One is contact, then is close, then is near. Contact range is when muzzle is touching the body. Okay, so if you have a contact range shot, what will happen? We will have muzzle imprint on skin, stellate shaped big entry wound and blackening, singeing and tattooing in the track, not around the entry wound but in the track. On the other hand, when we see a close range entry wound, it is when the muzzle end of the gun is in the range of flame, the flame that comes out of the gun. If the flame is able to reach the body, it is called as a close range. Generally for pistol, the close range is 8 to 10 centimeter, but depending upon the variability of the guns, it could be, in the first 15 centimeter to 30 centimeter. Okay, because there are some other rifled weapons where the flame may travel up to 15 to 13 centimeter. In pistol, it is within the first 8 to 10 centimeters only. Now, whatever is the range of the flame, that's not important. What's important is, in close range, how is the wound going to look like? Now here the wound is going to look like eccentric shaped large entry wound, blackening, singeing and tattooing around the wound. In our question, we did see tattooing around the wound, but we did not see any blackening or singeing around the wound. Okay. Also, the size of the wound was normal round, which was not eccentric or large. Now, how about a near range entry wound? Near range is the range beyond flame but within gunpowder particle distribution, which means the muzzle end of the weapon is farther away from the body, so that when the shot is made, the flame does not reach the body, but gunpowder particles which are coming out from the muzzle end, they can come and impact the body. Okay. Now, when a shot is made from this range, what is the quality that we see? We find round entry wound commonly corresponding to the diameter of bullet, which means it will be a round kind of an entry wound, not very big in size, corresponding to the diameter of the bullet. Second, no blackening, no singeing or burning, because flame and smoke are not reaching the body, but tattooing present around the entry wound. Now, in our photograph, what did we see? We saw exactly the same phenomena. No blackening, no singeing, but tattooing present around the entry wound. The entry wound, which is normal, round in shape and small in size, which means the correct answer would be a pistol near range shot has been made on this person. Okay, let's come up to our next question. It comes from thermal injury. Okay, so we had 3-4 questions coming from the segment of injury. One from thermal injury, previous one was from firearm injury. Before that we saw one question from mechanical injury itself, that was cut on the palm. Okay, let's see this question. A 10-year-old child having burns at front of anterior part of right chest and front of right upper limb, front of right side of abdomen, front of right leg. What is the percentage of burns? So first of all, let's see what is the area that is being talked here. So we have a child having burns on certain areas of the body. The areas are front of anterior part of right chest. Okay, so we have right chest, this is burnt, the front of the anterior of right chest only. Then we have front of right upper limb. Okay, so we have right upper limb, the front of it is kind of burnt. Then we have front of right side of abdomen. Okay, so right side of abdomen is this area itself. The front of right side of abdomen is also burnt. And we have front of right leg. Okay, so right leg, this area is burnt. So in these areas, upper limb and leg has been given. There is no comment about hand and foot. This is very, very important, so one should remember. Now if you look at rule of Wallace or rule of 9 or the classification of Wallace, okay, what does it say? It says that upper limb is 9%, lower limb is 18%, front 9, back 9. Okay, chest completely is 9%, abdomen completely is 9%. Okay, According to this information, if we see the area burned in the child, what do we see? Upper limb, only the front of right upper limb has been burnt. So approximately 4.5%. Okay, because whole upper limb is 9. So front of the right upper limb would be 4.5%. Then lower limb, we have lower limb we have front of right leg. Okay, front of right leg would be approximately 9%. I would say front of right leg, if you take the whole right leg as 18%, then front of right leg would be half of it, that is 9%. Whole of chest is 9%. Okay, so right side of the front will be 4.5. Okay, and abdomen whole is 9%. So right aspect of the abdomen will again be 4.5. Now in the question I have specifically told you that the concept of hand and foot being involved is not given. They have only said upper limb and right leg, right upper limb, right leg. So you can say, if classically hand is not given, foot is not given, there could be a situation that out of the total percentage we may have -1% because probably hand may not be involved, and maybe -1% because the foot involvement is not given, only upper limb and hand is being given. Okay, and hand and feet correspond to 1% of the total segment in the respective area. So if you add up the total, it becomes approximately 4.5, 4.5 is 9 and 9 is 18, and 18 plus 4.5 is 22.5. Okay, minus 2%, which is close to 20.5%. Okay, so correct answer here would be option number B, which is 15 to 20%, because 20.5% is close to option number B. But now many of us would advocate that the age of the child which has been given is 10 years. The rule of 9 calculation is commonly applicable to adult people. So what happens to the calculation of body surface area in a child of 10 years of age? See, in children, body surface area with increasing age, that is 1, 2, 3, 4, 5, 6 years, 10 years, 12 years, the body surface area is given by Lund and Browder charts. Lund's and Browder charts supplies us the information of varying of the body surface area while a child develops towards adulthood. And according to the information that we have available from Lund and Browder chart, the head and neck at 10 years of age will have a total body surface area of close to 16%, not 9% as is seen in adults. And similarly, the lower limb at 10 years is approximately 13.5% of the total body surface area, not 18% as we see in adults. So this is the variation by examining Lund and Broder chart at the age of 10. Now with this information also, if we come back to our question, what would we see? Because no burns were involving head and neck region, so there is no requirement of increasing of the body surface area, but the burn was involving the lower limb, and lower limb at the age of 10 is 13.5% of the total body surface area, which means in lower limb calculation we should have taken normal as 13.5, which means while the front of the right lower limb has been burnt, the half of it would be 6.75% only, and thus the total would have been even lesser than 22.5. The total in this case would have been close to 4.5 plus 4.5 is 9, then 4.5 is 13.5, plus 6 is 19.5, and then 0.75, which is 20.25%. And when we minus the 1% of probable exclusion of hand and feet, it will come back again to 18.25%. And even if we do not reduce the 2% of hand and feet, it will still remain as 20.25, which is again close to 15 to 20. So the answer 15 to 20 remains constant. So what I wanted to highlight here was that even if we do not remember the Lund and Broder charts and the respective body surfaces area of the increasing infant to toddler to adult body, if we only remember one concept, that as the child grows from infancy to adulthood, the shifts in body surface area does happen, but the most major shift is that when the child is infant, the body surface area of head is much more as compared to lower limb, and when the child grows, the body surface area of the head reduces and the lower limb surface area increases. Okay, even if you have the knowledge of this concept and you apply simple rule of 9, more or less your answer would always be in the correct estimates. Okay, let's move further. Question number 7. This time question number 7 came from a specific topic of virginity. Okay, the question was very simple. The question wanted you to identify the type of hymen which was shown in the question, and as per the recalls, what I've understood, the kind of hymen which was shown in the picture was this kind of a hymen which I am highlighting right now. Okay, a hymen having two openings in between which there is a membranous mucous membrane or membrane present. This kind of a hymen is called as a septate hymen. Okay, so the correct answer is septate hymen, but I have bought many other pictures of hymen for you. There are many varieties of hymen. Some of them are very common. As you can see, picture number 1 represents annular hymen, one single opening but not very large. Second is semilunar hymen, bigger than annular opening. Third is a very important kind of a hymen called as Fimbriated Hymen. You can see the fimbrias of hymen in a zigzag fashion going towards the vaginal orifice. So this is vaginal wall. Okay. In between here, this is the hymen membrane. Hymen membrane is hanging from the vaginal wall. Then we have septate hymen. Then we have which is figure number 4. Figure number 5 is cribriform hymen, lot of dot openings into the membrane of hymen. Then we have picture number 6. There is no opening in the hymen seen, which is called as the imperforate hymen. Okay. And then we have picture number 7, a hymen which is open in a vertical slit like fashion called as the vertical hymen. There are many other kind of hymenal presentations. We talk about the medico-legal importances of a very important kind of hymen, fimbriated hymen, how to distinguish it from an actual tear in our classes, where we do talk about utilization of an important structure which are called as Gleisterkeen rods to correctly identify the hymen tear also. Okay, so for right now I can only say as per the recall, the picture that was shown to you was a picture of septate hymen. Let's move further. Question number 8, coming from subtopic of asphyxia. Question says a dead body is brought with ligature mark on neck. The mark is below the thyroid cartilage. Okay, so we have two informations right now, that is there is a ligature mark on neck. The ligature mark is below the thyroid cartilage. The presentation of the ligature mark is that the ligature mark is transverse and it is completely encircling the neck. There is no salivarily dribbling noted. So very important negative finding is also being given, because presence of it, that is dribbling of saliva, presence of dribbling of saliva, hold on, highly favors hanging. Okay. Also in cases of hanging, there would be a ligature mark, but that ligature mark would not be transverse. The ligature mark will be oblique. And the expectancy of that ligature mark is above the level of thyroid cartilage. So what have we seen in the question? There is a ligature mark which is not oblique, it is transverse, it is below the level of thyroid cartilage, and it is completely encircling the neck. And there is no salivary dribbling. So hanging is possibly ruled out. Okay. Next is throttling, which is also ruled out, because in throttling we do not have development of a ligature mark. We may have development of sixpenny bruises or bruises due to finger pulps on the neck, because in throttling there is compression of neck by bare hands. There could also be presence of concentric nail abrasions on the neck. Okay. Mugging is also ruled out, because mugging is strangling somebody's neck in elbow or foot grasp. In this case also ligature mark pattern would not develop on the neck. So what we are left with as an exclusion itself is ligature strangulation. And we read this in the chapter of asphyxia again and again, that when we have a ligature mark which is transverse on its appearance on the neck, it completely encircles the neck, its level is below the level of thyroid cartilage, it goes more in favor of ligature strangulation as compared to hanging. So again I would say this question was very straightforward, very classical question, and the level of difficulty was normal to moderate. It was very simple, good enough area to ask a question. Okay, question number 9. It comes from toxicology. A 40-year-old male has acute loss of hair, specifically noted at lateral part of eyebrow and eyelash. Now this is a very critical information. Some behavioral abnormality is also noted by his wife, who brings him to a doctor. On examination, something is found on his fingernails, and depending upon that finding, the doctor makes a diagnosis. What is the diagnosis? There are 4 metallic poisons which were given in the option: thallium, arsenic, lead and mercury. Okay. Now mercury poisoning, it develops neuropsychiatric features. So definitely some neurological behavioral pattern changes may be observed, but then mercury poisoning does not cause any acute loss of hair or typically loss of hair from eyebrow and eyelashes. Okay, so mercury poisoning is ruled out. Lead poisoning also doesn't lead to these complications, so even this is ruled out. We are left with thallium and arsenic poisoning. Arsenic poisoning does cause nail features changes. The nail changes are Eldridge-Mees lines. Arsenic poisoning also causes alopecia. It does cause alopecia, okay, but not very characteristic alopecia from the lateral eyebrow and eyelashes only. It can cause regression of the male bald pattern of hair. So arsenic poisoning could be a choice because we have fingernails, some pathology in fingernails as an option, but in arsenic we do not actually see behavioral changes, but yes, it can cause depression. It can cause depression in its chronic poisoning. Now if you look at thallium poisoning, it causes typical hair loss from eyebrows or eyelashes. It causes psychiatric changes in a person. And the funny thing is, even in thallium there is development of Eldridge-Mees lines in nails. Eldridge-Mees lines are, if you see nail of a finger, if you'll say there is a nail like this, Eldridge-Mees lines are these kind of white color transverse line. White transverse line on males, which develops in many metallic poisoning. Arsenic and thallium are two very common. So depending upon the presence of symptom in thallium ticks all the boxes. The best possible answer in this case is thallium poisoning. Okay. Question number 10. The enzyme affected in lead poisoning is, this is a very simple kind of a question, direct question about lead poisoning, and direct question relating to the pathology caused by lead poisoning. Option number A, ferrochelatase. Lead poisoning leads to depression of enzyme in heme synthesis. There are two important enzymes which are depressed. One is ALA dehydratase and second is ferrochelatase. Okay, these are two very important enzymes present inside the RBC where heme synthesis happen, which are depressed due to chronic lead poisoning, leading to anemia in chronic lead poisoning. Very direct, simple question. Okay. Next, question number 11, again from toxicology. A 3-year-old child is brought to emergency in a comatose condition with history of consumption of iron tablets. So a direct history of iron tablet consumption is given. So looks like a toxicity of iron. So it's a case of iron toxicity of or iron poisoning. He is having abdominal pain and has had diarrhea and vomiting. The treatment is, so basically symptoms of iron poisoning has also been given: abdominal pain, diarrhea and vomiting with clear-cut history of iron tablets intake. The kind of treatment that is needed to be given is the compound which is helpful in acute iron poisoning, and that compound is desferrioxamine. This is something that we read in PSM, this is something we read in forensic medicine, this is something we read in medicine, this is something we read in pediatrics, this is something we read in pharmacology. So not a great deal of description is required here. The answer is very, very clear cut. Okay, let's move to next question. Again from toxicology. Good amount of questions come from toxicology, but all those questions were very direct, very, very clear information seeking questions, as you would have seen up till now. Again a very direct question. The antidote for opioid poisoning is, there could not be any more direct question than this. What is the antidote for opioid poisoning? The answer is very simple. It is naloxone. Okay, again this is something which we read in pharmacology, forensic and medicine day in and day out. Okay, let's move to our last question. Question number 13. A girl has been brought to emergency with paracetamol poisoning. The antidote is, again very clear poisoning asked, having a very day-to-day clinical manifestation. A lot of children come to emergencies with paracetamol toxicity. Okay, so paracetamol toxicity, the antidote is N-acetylcysteine. Again a very clear question, very clear answer. So these were 13 different questions that had come up in this year's NEETPG examination. As you would have seen, last few questions very direct, very specific questions. So good to good to understand that in NEETPG very relevant day-to-day life toxicity direct treatment questions are asked, which are very important for social practice of a doctor. Okay, hopefully you people gave a good exam. The results are awaited, fingers are crossed. Let's hope the best for everyone. Okay, till the time we meet again to discuss something different related to forensic medicine. I'll take leave from you. Bye, keep your preparations on, and best of luck for results to everyone. Bye bye.